Alright, so this is chapter 27. It's Antilipemic Drugs. It starts on page 443 in your pharmacology text. And for ATI, it is chapter 23. We'll talk about primary and secondary hyperlipidemia, types of lipoproteins and the role that they play in cardiovascular disease, and also the role that they play in hyperlipidemia. We'll talk about the different drugs and their classes, the mechanism of action, and of course their adverse effects, and then nursing implications for patients taking the antilipemic drugs. So triglycerides and cholesterol are the two primary forms of lipids in the blood. They're both water-insoluble fats that must be bound to apolipid proteins. The combination of triglycerides or cholesterol with the apolipoprotein is referred to as a lipoprotein, And then lipoproteins transport lipids in the blood. Just as a quick review, triglycerides function as an energy source and are stored in adipose tissue, and then cholesterol is primarily used to make steroid hormones, cell membranes, and then also bile acids. The lipoproteins are classified by their density and the type of lipoproteins that they contain. There's very low density lipoproteins, or VLDL, that are produced by the liver, and then they transport endogenous lipids to the cells. There are low density lipoproteins, or LDLs, and then there are high density lipoproteins, which are responsible for like the recycling of cholesterol. They're also known as the good proteins. We'll talk about them a little bit later. There's also some intermediate density lipoproteins, or IDLs, that are we'll talk about in just a bit when we talk about physiology, a little bit of physiology. There is a table in your book that is 27-1. It's on page 445, and it shows this classification for the lipoproteins. So this diagram shows cholesterol homeostasis. The process is that fats are brought into the body through the diet, or what we eat. The fats are then broken down in the small intestines to form triglycerides. And if you remember from the lymphatic system lecture, that the lymph plays a role in absorption in the intestines. So the triglycerides are incorporated into the chylomicrons, and they're absorbed into the lymphatic tissue. The chylomicrons transport the lipids to the liver, where they're used to make steroid hormones, bile acids, and then also components of the cells in the peripheral body. As you can see from the diagram, the liver here, it plays a major role. It's the major organ for lipid metabolism. When you look at all the arrows that are on here, somehow they touch the liver in some way or another. So again, it plays a major role. The liver produces VLDL, which transports endogenous lipids to the peripheral cells. While it's in circulation, the VLDL is cleaved by lipoprotein lipase and then loses triglycerides, and that creates that IDL, or the intermediate. And then the IDL is cleaved by the same process as the and then the LDL, or the lower density lipid, is created. So after this process, cholesterol is about all that remains in the LDL. Tissues such as the endocrine cells that require cholesterol for synthesis of steroid hormones will have receptor sites for the LDL. The liver also contains LDL receptor sites, and about half of the IDL and the LDL are reabsorbed from circulation into the liver. The HDL, or the good lipid, as we talked about before, as it's called because it's believed to have a cardioprotective type of function, is produced by the liver and the intestines, and it's also formed when the chylomicrons are broken down. Lipids are not used by the peripheral cells, or the lipids that are not used by the peripheral cells are then transferred as cholesterol esters to HDL. And then HDL then transfers the cholesterol esters to IDL to be returned to the liver. So the HDL is also responsible for recycling cholesterol. If too much cholesterol is present in the liver, then the number of receptor sites is decreased, so LDL accumulates in the blood. One of the major functions of the liver is to make cholesterol, and this process requires acetyl coenzyme A reductase. So if the enzyme is inhibited, cholesterol production by the liver will be decreased. I know that this is a bit complex, but a good understanding of the process will really help out in understanding how all of the medications are going to work. All right. So lipids and lipoproteins participate in the formation of atherosclerotic plaque, which leads to coronary heart disease. Normal total cholesterol levels should be less than 200. The risk for coronary heart disease is 3 to 4 times higher for people with cholesterol levels, or total cholesterol levels of 300 as compared to those with cholesterol levels that are less than 200. And here you can see in this picture, this is a fat streak, or how you can see that that fat or cholesterol has built up and caused those atherosclerotic plaques. So you can see how that narrows the vessel significantly. So antilipemic drugs, these are drugs that are used to lower lipid levels. They're used as adjunct therapy to diet as well. Drug choice is based on specific lipid profiles of the patient or phenotyping. There are 5 different phenotypes, and these phenotypes are defined by plasma concentrations of total cholesterol, triglycerides, and lipoprotein fractions. Table 27.2, it's on the bottom of page 447, describes the type of hyperlipidemias and those different phenotypes. And then I've put here on the screen what screenings we do for like total cholesterol, HDL, LDL, and triglycerides, and what the target ranges would be. So treatment guidelines. So really all reasonable non-drug means of controlling blood cholesterol levels, such as diet and exercise, should definitely be tried first. Their recommendation is that they are tried for at least 6 months, and then if they're still found to fail after a complete 6-month trial, then drug therapy would be considered. There are currently 4 classes of drugs used to treat dyslipidemia. There are the HMG-CoA reductase inhibitors, bile acid sequestrants, B vitamins or niacin, and then fibric acid derivatives or fibrates. And then there's also one cholesterol absorption inhibitor, and then there's also some combination drugs that may be used as well. And then we'll talk briefly about herbals that are also used to reduce lipid levels. So the HMG CoA reductase inhibitors are also known as statins. And you can see all of their names have the word statin in them. This class of medication competitively inhibits the HMG-CoA reductase. Drugs in this class that are available on the market are pravastatin, simvastatin, atorvastatin, fluvastatin, so all the little statins, Crestor, all of those, but they're all have statin in their name. So remember from earlier that HMG-CoA reductase is required in the production of cholesterol in the liver. So statins inhibit this enzyme, which is used by the liver to produce cholesterol. So the rate of cholesterol production would be decreased. They're a first-line drug for therapy for hypercholesterolemia. They treat types 2A and 2B, and that's from that phenotyping that we talked about earlier. They reduce LDL levels by 30 to 40%. They increase HDL levels, which is that good cholesterol level, 2 to 15%, and then reduce triglycerides by 10 to 30%. They are contraindicated if there is a known drug allergy. They're also contraindicated in pregnancy, and they shouldn't be used with people with liver disease or those who have an elevation in liver enzymes. The most common problems that are seen with these types of, or this class of drugs, is mild transient GI disturbances, rash, and headache. But there also can be a problem with myopathy or muscle pain that could possibly lead to a serious condition called rhabdomyolysis, and we talked about this, I think, a little bit at some point. But this is caused by the breakdown of muscle proteins, and then the breakdown of the muscle protein myoglobin is then excreted in the urine, and then that abnormal excretion of the myoglobin, which is really big molecules, can place a severe strain on the kidneys and then lead to acute renal failure, and if it's not caught in time, can also lead to death. It can also cause elevations in liver enzymes, or it can cause liver disease as well. So this is why this class of drugs is contraindicated in patients with liver disease or those that have elevated liver enzymes already. So there's quite a few drug interactions with this class of drugs. You can look at table 27.5 on the top of page 449 for the list of drug interactions. It also talks about the mechanisms of why the interactions happen and also the effects. So bile sequestrants, these are second-line drugs. They're used as an alternate for patients who really can't tolerate the statins. These drugs will lower LDL by 15 to 30% and also increase HDLs by 3 to 8%. They also increase hepatic triglycerides and VLDL production, which may result in about a 10 to 15% increase in triglyceride levels. So some of the ones that you'll see on the market, Sequestrant you see pretty often, Welchlor, and then Clostid also. I haven't actually seen Clostid all that much. These drugs, besides being called bile acid sequestrants, might also be called acid binding resins. So they work by preventing reabsorption of bile acids from the small intestines, which is then excreted in bowel movements. The bile acids are necessary for absorption of cholesterol from the small intestines and are also synthesized from cholesterol by the liver. The more that the bile acids are excreted in the feces, the more that the liver converts cholesterol to bile acids. So this reduces cholesterol that's in circulation. And then the liver will try to compensate by increasing the LDL receptor sites. And then the circulating LDL binds to these receptor sites, again reducing the LDL that's circulating in the bloodstream. So these are used for type 2 hyperlipoproteinemia, either as a primary or adjunct therapy. They're also used, the cholestyramine is also used to relieve pruritus associated with partial biliary obstruction. And again, as an adjunct, they may be used along with statins. And then the closervalam may be tolerated better by patients who are intolerant to other antilipemic therapy. So higher risk patients like organ transplant recipients or those with serious liver or kidney disease might tolerate that drug a little bit better. So the major adverse effects with these drugs are constipation, heartburn, nausea, belching, and bloating. these adverse effects tend to disappear over time. You can start them on, or they could be started, not as particularly as nurses would start them on lower doses, but they can be started on lower doses, and then they could also take them with meals, and this will help to reduce these types of effects that can happen. Alright, so niacin, or vitamin B3, this has lipid-lowering properties, but requires much higher doses than when used just as a vitamin or a supplement alone. It is very effective, it's inexpensive, and it's often used in combination with other lipid-lowering drugs to enhance the lipid-lowering effects. So the mechanism is not exactly known, but it's thought to increase activity of lipase, which breaks down the lipids, and then reduces the metabolism and catabolism of cholesterol and triglycerides. It decreases LDLs by about 10 to 20%, and then triglyceride levels 30 to 70%, and then increases HDL from 20 to 35%. So these are effective in lowering triglycerides, total serum cholesterol, and LDL levels. They also increase HDL levels. They're effective in the treatment of those phenotypes 2A, 2B, and 3, 4, and also 5. So all of them. Isn't that great? They're contraindicated in people with liver disease, hypertension, or peptic ulcers, and any active type of hemorrhagic process. And this is because niacin causes the release of histamines, which increases gastric mobility and also acid secretion. And it may also stimulate the fibrinolytic system to break down fibrin clots. So we got to be really careful in our assessment before we start focus on these types of drugs. So adverse effects, flushing, which is caused by a histamine release, pruritus, or GI distress. A small dose of aspirin or some type of anti-inflammatory taken about 30 minutes prior to the niacin can help with the flushing. Again, starting them on a low dose and then increasing gradually, and also taking meds with meals can help to minimize the effects. So the fibric acid derivatives, they're also known as fibrates. This is gimfibrazole or fenofibrate. So Lopid or Tricor, I'm sure you guys might have heard of those ones. They primarily affect triglyceride levels, but may also lower total cholesterol and LDL, and then raise HDL as well. So they're also believed to work by activating lipase, which breaks down cholesterol. They also suppress the release of free fatty acids from adipose tissue, inhibit synthesis of triglycerides in the liver, and increase secretion of cholesterol in the bile. They can also induce changes in coagulation. There is a tendency toward a decrease in the platelet adhesiveness, and they can also cause an increase in plasma fibrinolysis and clots to be broken down. So we'll have to be really careful with these type of medications if folks are on other types of anticoagulant therapy. So these are used in the treatment of type 3, 4, and 5 hyperlipidemias. The fibric acid derivatives, gimfibrazole and fenofibrate, decrease the triglyceride levels and increase the HDL level, cholesterol levels by as much as about 25%. So adverse effects include abdominal discomfort, diarrhea, nausea, blurred vision, headache. They're at an increased risk for gallstones, prolonged prothrombin time, and then liver studies may show increase in enzyme levels, so we'll want to monitor those pretty closely. Some of the drug interactions already mentioned, oral anticoagulants. So the gimfibrazole can increase the action of anticoagulants, so patients taking Coumadin may need to have an adjustment to their dose. With statins, it can cause a risk of inflammation of the muscles, or myalgias, or rhabdomyolysis can also be increased. As far as laboratory test reactions, in patients that are taking gimfibrazole, it can show a decreased hemoglobin level and hematocrit value and white blood cell count, and increased activated clotting times, lactate, and also bilirubin levels. So cholesterol absorption inhibitors, there's only one of these on the market right now, and that's Zetia. And it inhibits absorption of cholesterol and related sterols from the small intestines. And this results in a reduced total cholesterol, LDH, and a triglyceride level as well. It also will increase HDL levels, and it's often combined with a statin drug as an adjunct. They're still doing a lot of research on this type of drug, and currently it's only recommended when patients have not responded to other therapies. It also has been shown to be effective in reducing the risk of vascular events in patients with moderate to severe chronic kidney disease. So they're still doing clinical trials. They're still doing lots of research to see how else this medication might be helpful. And lastly, there's a lot of different herbal products on the market, or lots of different herbals that are also used to help reduce lipids. So one of those would be garlic, and it is used for many different things, so antispasmodic, antihypertensive, antiplatelet, but it's also used as a lipid reducer. The adverse effects here are dermatitis, vomiting, diarrhea, flatulence, that antiplatelet activity, so we want to be careful with taking garlic with anticoagulants or antiplatelets, or also with some of these other medications that we've discussed during this lecture. It also has possible interactions with warfarin and also diazepam. So we'll want to make sure, again, with any type of drug that we're going to start people on, whether it's an herbal over-the-counter product or a prescription, that what medications they're currently on, so we can see if there are any interactions that we need to be aware of. And then it can also enhance bleeding when taken with NSAIDs. Another herbal product that's used to help with lipid levels is flax. Both the seed and the oil of the plant are used. It's used for atherosclerosis, hypercholesterolemia, GI distress, and menopausal symptoms. It could cause diarrhea, and then, of course, like any of them, you can have allergic reaction. And then it has possible interactions with anti-diabetic drugs and anticoagulants. Another herbal product that is used are those omega-3 fatty acids, so the fish oil products. These are used to reduce cholesterol. Here, patients may have a rash. There's that belching. Sometimes if they're taking the fish oil caplets, they'll have that fishy belching, which is kind of gross, I guess, or irritating to some. But there are a lot of omega-3 fish oil products nowadays that are on the market that do not have that fishy taste, I guess. They also could have an allergic reaction, and then again, there's a potential interaction with anticoagulant drugs as well. So for nursing implications, of course, before we begin any therapy, we want to obtain a thorough health history and medication history. We want to know about any family history, previous problems, what are their dietary issues, what medications are they currently taking, since when you look at the lists that are in the book, there are a lot of drug interactions here that we need to be aware of. We also want to assess their dietary patterns, their exercise level, what is their weight, their height, their vital signs, are they smokers, do they use alcohol? I already mentioned family history. We also want to know if they have any allergies to any medications or anything at all. That would be important to know. We want to assess for contraindications, conditions that require cautions with use, and also all of those drug interactions. So contraindications include biliary obstruction, liver dysfunction, and active liver disease. We want to obtain baseline liver function studies. If the patient's on long-term therapy, they may need supplemental fat-soluble vitamins like A, D, and K. And we'll refer to guidelines regarding administration times and meals. So you want to look at the guidelines for each one of those different classes of medications to see when should we be administering them and should they be administered with meals. With some of them, it's really helpful to take them with meals because that'll help to decrease the adverse effects. We definitely are going to counsel patients concerning diet and nutrition on an ongoing basis because, again, if they can lose weight and decrease the amount of fat that they're taking into their diet, that's certainly going to help with their cholesterol levels for sure, or their lipid levels, I should say. We want to instruct them on the proper procedure for taking the medications. Powdered forms need to be taken with a liquid, and they need to be mixed thoroughly, not stirred, and never ever taken dry. Other medications should be taken 1 hour before or 4 to 6 hours after meals to avoid interference with absorption. And to minimize adverse effects of niacin, we want to start them on a low dose initially and then gradually increase it. They can also take it with meals, and then we also talked that you could take or have them take a small dose of aspirin or NSAIDs about 30 minutes before the niacin to also minimize that flushing. We also want to provide teaching regarding the use of NSAIDs and aspirins because, again, a lot of these medications do have issues with increasing bleeding times or interrupting something within the coagulation process. So, again, if we take NSAIDs or aspirins, that could potentiate that problem. So we want to make sure that we talk to them about those. And we want to inform the patient that these drugs may not they may take several weeks to show their effectiveness. So we want them to stay on the regimen, and that they will be checked again later to see how they're doing. Usually they'll check blood work about a month after they're started on these types of medications. You want to instruct the patient to report persistent GI upset, constipation, any abnormal or unusual bleeding, or, of course, yellow discoloration of the skin, which could indicate that there's a problem with liver function. We want to monitor them for adverse effects, again, including that increased liver enzyme studies, so they'll need to have those monitored periodically as well. And then we want to monitor them for therapeutic effects. So we want to see that they're having a reduced total cholesterol and triglyceride level, and then a higher HDL level. So again, if you have any questions, you can post them on the discussion forum. There is a forum open now. You can discuss that under questions. You can also email me, call me, or text me. And then if you have any questions, we can also talk about this in class. There is an assignment along with this one, a discussion forum. I would like you to post one multiple choice question from the content in this chapter for your peers to answer. And then I want you to answer one peer question posted and include the rationale for the correct answer. Do not answer a question that has already been answered by one of your peers. And this will be due next Sunday by 5 o'clock. If you have any questions, please let me know.